AP or AP axial toes. You have a choice. Stop. You have a choice to do AP, which would mean you use a sponge and you do not have to angle the tube, right? So if the toes are like this, you can wedge a sponge under there to make the toes appear like that so you can get inside the joints. If you're not going to use a sponge, you got to somehow get inside the joints there. So you're going to do a 10 to 15 degree angle towards the calcaneus to prevent foreshortening and visualize joint spaces. Central ray for all AP toes is MTP. That sounds good. All right, MTP joint. Then you got an oblique toe. If you're doing toe number 1 or 2, it needs to be a medial oblique toe. If you're doing 4 or 5, it needs to be a lateral oblique toe. If you're doing third, you can pick. And people's toes are all chewed up and gnarly, so it might take anywhere between 30 and 45 degrees. You just look at the toe and see how much rotation is necessary to kind of get that toe by itself. MTP, beep. Then we need a lateral toe. If it is digit 1 or 2, it's going to be a lateral medial. If it's digit 4 or 5, it's going to be a medial lateral. If it's digit 3, you pick. And central ray, if it's digit number 2 through 5, is PIP. If it's digit number 1, it's IP. Beep. All right, tangential sesamoids. Patient can be either prone or supine. The prone one is less OID. I think that's the one everyone practice because it's easier. Central ray is on MTP, and you're taking the plantar surface of the foot and you're pushing it back until it makes a 15 to 20 degree angle to get that sesamoid out by itself. Shield them on their back because they're flipped over. Beep. All right, AP axial foot. Your foot is not flat. It has an arch to it. So we need a tube angle, and it is 10 degrees. And then your book says it might not even take that much. If someone has a super flat foot, you might not even angle at all. But 10 degrees towards the calcaneus. Central ray is at the base of the third metatarsal. Thank you. Beep. All right, now we need an oblique foot, and routine is a medial oblique foot, and it's between 30 and 40 degrees. Central ray is base of the third metatarsal. But if your test says something about the base of the first or second metatarsal, first or second cuneiform, or the navicular, then we're going to do a lateral oblique foot, which is not routine, it's something special, and it only requires 30 degree obliquity. Central ray is still base of the third metatarsal. All right, lateral foot is always a medial lateral, and the central ray is medial cuneiform. Foot doesn't need to be flexed or anything, just include the entire foot. You need to make sure that the plantar surface is perpendicular to the IR, so many times you have to take the person's knee and lift, lift, lift until the bottom of the foot's exactly perpendicular, and you want all the metatarsals superimposed. Now there is a special thing where if you do a lateral medial projection, we don't ever do that, but that automatically puts the foot in a true lateral where you don't have to move the foot any. The metatarsals will be completely superimposed, but we don't do that because it's painful for the patient. Weight-bearing feet, AP axial and lateral weight-bearing. The only thing you need to know about those is that it demonstrates longitudinal arches. That's it. Plantodorsal axial calcaneus. You need to make sure that the plantar surface is exactly perpendicular to the IR. Angle the tube 40 degrees towards the calcaneus. Central ray is at the base of the third metatarsal. You need to include the subtalar or talocalcaneal joint, and the sustentaculum tali should be seen on profile medially. Then you do a lateral calcaneus. It's always a medial lateral projection, and the central ray is 1 inch distal to the medial malleolus. That's it. All right, AP ankle, you're going to put the toes straight up in the air, dorsiflex. No, you don't have to dorsiflex. No. Okay, just relaxed ankle. When you do that and the toes are straight up in the air, the intermalleolar line is not going to be parallel to the IR because the lateral malleolus is a ½ an inch more posterior. So if this is my right leg, my line's going to look like this. And the central ray is just intermalleolar. Beep. Next picture, you want to see inside that ankle mortise. So you're going to do a 15 to 20 degree medial rotation, and that will place the intermalleolar line parallel to the IR. Central rays, intermalleolar. Beep. Now you need an internal oblique, so you're going to keep rolling medially, and that's going to be 45 degrees. And what's special about that one is it demonstrates the distotibial fibular joint, and why that's special is because it's fibrous, when most of our joints down there are synovial. Then you're going to roll out into a medial lateral ankle, central raise on medial malleolus, and that one you do want to dorsiflex the joint, the ankle to open joint spaces. Stress views, only thing you need to know about that, it's the radiologist that's going to grab the patient and they're going to push both of their ankles into inversion. You're going to shoot the picture, you're going to change the cassette, they're going to grab them again, push them into eversion, shoot it. And those are to look for ligament tears or ruptures in the ankle. Tib fib include the ankle joint and the knee joint. Beep. Roll them laterally, mediolateral. Beep. All right, AP knee. All right, everybody needs a 3 to 5 medial rotation, boop, which is barely anything, and the reason is we want to get that interepicondylar line and place it parallel to the IR. You want to angle your tube so that the CR is parallel to the tibial plateau, and the way you know that is by somebody's butt. If their butt is less than 19 centimeters, that is a small butt, so you're going to angle 3 to 5 degrees caudad to get parallel to the plateau. If somebody's butt is over 24 centimeters, 4? Okay, over 24, that means they got a big butt, and you're going to angle 3 to 5 cephalic. And if they're between 19 and 24, you're not going to angle at all. Yep, central ray is 1/2 inch distal to the apex of the patella. Beep. Then you need an external oblique. You're going to let their leg just fall out naturally, 45 degrees. When you roll out externally, it's going to put the medial condyle on profile. It's going to completely hide the fibula behind the tibia. Then you're going to roll 45 degrees medially. That's going to put the lateral condyle on profile, and it's also going to separate the proximal tibiofibular joint. Then we need a lateral knee. The flexion is 20 to 30 degrees, and your medial condyle extends more distally than your lateral, so it's going to kind of block the joint space. I always do this with the fingers. It's going to block it. So I need to take my CR and I need to angle it 5 to 7 degrees cephalic to get inside that joint space. And my central ray is 1 inch distal to the medial epicondyle. All right, I got weight-bearing knees. The only thing you need to know about that is you're looking for cartilage degeneration between the knee joint, and those would be your meniscus. All right, PA axial intercondylar fossa. You got 3 ways to see the intercondylar fossa. First one's PA axial, called the Camp Coventry. Patient's going to lie prone. You need to get a 40 to 50 degree bend of the back of their knee. Whatever that degree is, say it's 43 degrees, you need to angle your tube 43 degrees. And you're going to put your CR perpendicular to the lower leg and enter at the popliteal crease. Another way to do it is the Holmblad. They're going to get up on all fours. You're going to put the goniometer on the back of their thigh. They're going to lean forward until the goniometer reads anywhere between 20 and 30, which makes a 60, 70 degree flexion. And then you're going to enter on the popliteal crease. And this is where I start not knowing things. Then you got the AP axial. That's called the Bellclair method. They're going to flex their knees
20 to 40 to 50.
40 to 45, so they don't have as much flexion there. And then it's 1/2 inch distal to apex of the patella. Beep. All right, we got a PA patella. The reason we're doing it PA is to reduce OID. We still got to get that interepicondylar line parallel to the IR, so it's just a 5 degree internal rotation, hardly anything. Enter right on the crack or the popliteal crease. Beep. Then we got a lateral patella, and we want to keep the patella so that it's not inside that patellar surface. So it's just 5 to 10 degrees, hardly any flexion whatsoever. And then the CR is right behind the patella or the patellofemoral joint space. You got to make sure the patella is on profile. All right, then we got 3 ways to get the sunrise skyline view. We've got the Merchant, the Settegast, and the Houston. Merchant is a 40 degree knee angle. And knee flexion, and then the tube angle is, I'm only 40, but he thinks I'm between 50 and 60, so is it 50 and 60?
No, 30.
No, 30.
Merchant.
Merchant.
Oh, Merchant. They are asking 40, and I said, no, I'll give you 30. Okay, so 40 and 30 for the Merchant. Houston, we got a problem. I'm only 40, and he thinks I'm between 50 and 60. And then this, what?
45.
And what?
The tube angle is 45. And it's 50, 60.
Okay, 45. Okay, so I'm only 45, which I'm not yet. And then he thinks I'm between 50 and 60. And then the Setagast is the one you don't ever want to do if someone has a suspected fracture, because you have to flex all the way at 90 degrees, and that could take the two parts of the patella and snap them apart. But they'll all give you the exact same picture.
Tube angle,
15 to 20 tube angle for the Setagast. That's all I know. Okay, you can stop.